You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 475 of the podcast. And this one, I got back on Nate Gruner and Meaghan Cleary. Nate is a staff behavioural therapist at the Obsessive Compulsive Disorder Institute at McLean Hospital. Meaghan is a licensed mental health counsellor and a registered dance and movement therapist. She is also a behavioural therapist and group facilitator at the Obsessive Compulsive Disorder Institute at McLean Hospital, along with Nate. So in this one, we discuss what is functional analytic psychotherapy, or FAP for short, the rules of FAP, using the therapeutic relationship to create change, what FAP looks like in a session, case examples, the therapist training on FAP that we are running through the centre I co-run, integrating FAP with exposure and response prevention therapy and acceptance and commitment therapy, why I'm interested in FAP, and much more. And thank you to NoCD for supporting the podcast. NoCD offers effective and convenient therapy available in the US and outside the US. To find out more about NoCD, their therapy plans, if they currently take your insurance, or to download their free app, head to go.treatmyocd.com/the OCD stories, or the link will be in the episode description. So thank you to Nate and Meaghan for their time. It was awesome speaking with them. Interpersonal therapies and FAP is something that's piqued my interest for a while, so it was great to go into this in more detail. And of course, thank you to you guys for listening. As always, it means a lot. And without further ado, here is Nate and Meaghan. Welcome to the podcast, Nate and Meaghan.
Hey there.
Thanks for having me back on.
No worries.
And thanks for letting Meaghan join us.
Yeah, absolutely. I say there's always gaps when there's more than two guests, because then no one knows who to speak. So, so Nate, as you said, you've been on the podcast before, but it'd be good to get just an elevator pitch on who you are, and then Meaghan, just to introduce yourself as well.
So I'm at the OCD Institute at McLean Hospital, and I'm a behavior therapist there. I've been on your podcast twice before talking about functional analytic psychotherapy, and I invited Meaghan to join us today because we are eventually going to be doing a training on FAP for your clinic, which we'll talk about later in the episode. And I think Meaghan is one of the best therapists I know, and she really gets FAP. So she's here joining us today as well.
Nice.
Thank you, Nate. That's quite the introduction.
Yeah.
I think, so I am Meaghan. This is my first time on the podcast, though I have really sort of enjoyed listening to them for quite some time. And I'm currently at the OCD Institute. I've been here since as a behavioral therapist, 2021. Prior to that, I worked in sort of hospitals focused around eating disorder care. And sort of, I like to say sort of a bit of a regular therapist, as much as I am also a dance and a movement therapist. So for me, really thinking about how someone experiences their body, how they feel in their body, and also what they're communicating through that, and how their nervous system is just handling the world around them is sort of very much a passion of mine. So, and that's, I think, why I've always been so drawn to FAP, is that a lot of behavior is happening in a given interaction with someone that I'm working with, that bringing that into awareness and being able to work on that is something I've always been so curious about. And that's very much how Nate and I actually got connected around this.
Okay, amazing. So at McLean, is there a cohort of therapists who have taken to FAP and are using it, or is it mandated down through McLean? How did FAP become a thing at McLean?
Well, I'll tell you the short story and then Meaghan can add to it. So I got interested in FAP probably, I think I said this on a previous podcast, probably around 2015. And I got supervised in it and then really started doing it more with patients. And then when I went on your podcast in 2021, I started realizing that we should probably more formally be rolling it out at the OCD Institute. And it wasn't clear yet to the staff that this was something that we were going to be doing with our patients. We really were on board with ERP and ACT and the evidence-based therapies for OCD, but we really didn't know that interpersonal work was something that we would do at the OCDI. And so Meaghan and I started, I think it was in 2022, a FAP kind of consultation team with the BTs, the behavior therapists at our clinic. And what I've found interesting is I think they're very interested in FAP, the staff here, the counselors who Meaghan supervises, the entry-level counselors and the senior therapists here. But when it comes to us actually living and breathing FAP in our interactions with each other, I think it's been very scary for us. So Meaghan and I have tried to do like this consultation group where we give each other feedback on how we're experiencing each other, which is, we'll get into that in this podcast. And I think our staff have been pretty nervous about that. It's been very vulnerable for them to share with each other things that are happening interpersonally in the moment.
Yeah.
I definitely see a lot of our staff really seeing the utility in it, is that, we introduced a FAP group amongst our patients sort of weekly. And it has had such a wonderful response from the patients around it being something they look forward to, something that feels really integral to their treatment. And so I do think that we see as staff how important it is, and how, given that we are a residential setting, we do see so much of these people, right? In not only just our individual sessions, but groups, sort of personal interaction just on the unit. And I think there's a lot of merit in sort of bringing attention to those almost like target behaviors that could be worked on in treatment. But I think very much so we're still like in the very early stages of like how we really fully incorporate that into our program.
Yeah. Yeah, absolutely. And I think, FAP it's not new. I don't know when it was created, but it's not like yesterday, but it's been around long enough that you could argue it probably should be bigger than it is. And partly I think that is there's just no trainings. When I look to do more, I did supervision with Nate, actually. He supervised me for a little bit on FAP and OCD. And but then when I looked at other trainings, I could find one through a website. It was like a 2-hour training. I couldn't find any other trainings or diplomas or courses. Definitely none on OCD. I guess I don't know what my question is here. Maybe it's just why? Why is it? Are they just terrible at marketing themselves, or is it rubbish? Like what? Why? I'm just putting my hat on.
I have a quick thought on this, and I want to hear what Meaghan has to say. I do have a feeling they haven't marketed themselves as well as the ACT and ERP community, but I actually think it's pretty hard to sell FAP to clinicians who have been used to using treatment protocols. So this is especially true in evidence-based therapy, and I was so guilty of this early in my career. I could basically do therapy with patients where I said a bunch of smart things that I knew about ERP and ACT that were all on target, but they had nothing to do with my relationship with the patient. They were mostly focused on like the thing the patient needed to do internally or like out in their life that would make their life better, but not between me and the patient. And I think a lot of clinicians are scared to talk about what's happening in the room between them and their clients. And the interesting thing about Meaghan is I think Meaghan's always been drawn to that approach. To be honest with you, I've always been drawn to it as well because I just really like genuine relationships in my life. But I was sort of trained not to do that with my patients, to really talk about what's happening between us. And I think a lot of clinicians are scared of that.
Yeah.
I totally agree, Nate. I think that there's this sort of like division. I was exposed to it more from like a psychodynamic approach. And I think there is sort of, it feels almost like this, bad thing to bring into behavioral work of like, oh, that's something, that is countertransference and that's something separate and you manage it in supervision, but it's not something to sort of bring into the work. So I think there is this hesitancy of like how, and almost in a very like rigid, like concrete way ourselves of like, how do I do this? Like, please show me the steps of how I might sort of implement this kind of work. And I have to say, even sometimes my pet peeve is like when someone says like, how do I do FAP, right? It's like they're looking to some sort of manual. And I think that's a big part of why it hasn't caught on as much as sort of ERP or ACT or just CBT, right? Classically. And it is challenging, I think, even when Nate and I sort of talk about it with other clinicians that we have, really to articulate it in a way that doesn't feel sort of even like going way too far past boundaries between patient, right, and therapist. I think there's a lot of fears that people have around misusing it. So in some ways, avoided it almost altogether.
Yeah. Yeah, I think that's a really, really good answer. I think, when you've been so focused on symptom reduction or externalizing things rather than, it always reminds me of Irvin Yalom, and in his The Gift of Therapy book, he says in that the here and now relationship is the most powerful thing we have, which is what FAP's using, right? Is what's happening in the here and now between therapist and client or patient. And FAP has kind of found a somewhat systematic way or structure to use that here and now relationship. So yeah, as you said, Meaghan, with like the psychodynamic stuff, they've been thinking this way for years. And then CBT went completely the other direction. And now maybe FAP is that bridge between the two. So what is FAP? What is functional analytic psychotherapy? How would we describe it to the people listening?
Do you want to start, Meaghan?
Take it away, Nate. Go for it.
Oh, okay. Well, I was going to say, so I'm going to answer the question, but what I was going to say is, I actually think in all of the evidence-based treatments, and by the way, when I say that FAP is an evidence-based treatment, I think a lot of people would argue that it's not, because it actually doesn't have enough randomized control trials backing it to say that it is. So this is still kind of emerging as an evidence-based treatment, but in all the evidence-based treatments, the only two that I know that target deep interpersonal connection are emotionally focused couples therapy. So anyone listening to this who's a couples therapist knows that that's one of the gold standard treatments for couples. And that therapy is all about expressing vulnerability and sort of hidden emotions and getting that reinforced with your partner. FAP is the only individual therapy that I know of that targets deep emotional connection and authentic self-expression as its primary target. And there are 5 rules of FAP that orient the therapy. So the first rule is watching for the things that the client does in your relationship with them that create connection or disconnection with you, the therapist. And assuming that those things that are showing up out in the world in their other relationships. So really seeing your relationship as a microcosm for how they're showing up out in the world. So you're watching for those, what we call clinically relevant behaviors to occur. And then the rule 2 is you're trying to evoke them in session. So a classic example is a client who's afraid of emotional closeness with other people. Meaghan might say to a client when they walk in, I was really looking forward to seeing you today. If she knows that that person struggles with letting in closeness, and then if that client was able to say something like, even if they were nervous, but said like, I was really looking forward to seeing you too, Meaghan would then do rule 3, which is to reinforce that person's effort to show more closeness with Meaghan. And rule 3 uses what we call natural reinforcement, which means Meaghan would respond how she actually feels, not some contrived way. But if she actually sees this person showing more authentic interest in being close with Meaghan, Meaghan might say something like, I really liked it when you paused and like looked at me and told me that you were also looking forward to seeing me today. The thing about rule 3 is that you have to make sure that when you reinforce someone, that it actually is reinforcing them. So rule 4 is checking to make sure that that happened, which means your intention of reinforcing them doesn't matter. What matters is that you actually were reinforcing. I think Meaghan is one of the most reinforcing people I know when it comes to vulnerability. So I'll let her speak about this. So rule 4 is checking your impact to make sure you actually reinforce the behavior you want. And then rule 5 is talking with the client about how they're going to take that thing that they started doing better with you in session out into their life and practice it with people who are likely to reinforce it out in the world. Those are the 5 rules of that.
Yeah, that's a good description. And, especially that last bit, is it considered a behavioral therapy as well? In some, yeah.
Yes. It's basically combining Skinner, meaning kind of classic behavioral principles, with all of this Yalom humanistic, kind of authentic interpersonal therapy. And I really think it's the behavior therapy effort to try to get the interpersonal relationship into the therapy.
Yeah, because I've seen it. Sorry, go on, Meaghan.
I was going to say, Stuart, made me incredibly happy to hear you reference Yalom, because that's very much actually like how I was almost introduced to FAP, is like via that idea. And I think it's, behavior's attempt to really start to track these really relevant behaviors that are occurring that might be related to their OCD or outside of their OCD, and actually give it a framework.
Yeah, I agree. I mean, that's where like Carl Rogers, he had some good ideas, some really good ideas, but I just find at times the humanistic approach, it just lacked that behavioral element that just pushed that change that extra bit. And I think that's maybe my prediction why it fell short a lot of the time, is there was just nothing creating the change. Obviously some conversations did, but there was no then extra element or structure. So I think sometimes humanistic therapists couldn't figure out what they were doing or why they were doing, or it was just on these core conditions.
Just to add to that, I think Meaghan and I have talked about this, and I know that Bob Kohlenberg and Mavis Sai, who developed FAP, talked about this, that I think I said this on your last podcast, that the way FAP started was Bob Kohlenberg was this hardcore behaviorist who was supervising Mavis Sai, and he was watching her do therapy, and he was realizing she's getting these amazing outcomes and having these amazing relationships with her patients. I want to try to understand in behavioral principles what she's doing. And I actually think when I met Meaghan and we started talking about therapy and OCD, I saw Meaghan just having amazing relationships with her clients and getting really good outcomes. But she was doing it with all this authenticity and kind of reinforcing, I think, like who the patient really is. And I think it was helpful for Meaghan to hear me say things like, you're doing rule 1, you're doing rule 2, that's a CRB1, that's a CRB2, to give actual behavioral terms to what she was doing.
Like speaking, it was like learning how to speak a new language and be that much more effective than I think in ERP. And in some ways, right, I think we talk about, even at McLean here, it's that ERP is being the person that you want to be in the face of anything that is difficult for you. And like how much vulnerability, right, is entailed within that. And it also gives a person, I think, a reference point, right, where if we're able to sort of articulate the behavior, track it, shape it, like move it in a direction that does start to serve them, it is so much, it's very clarifying, I think, both for me as the therapist, but also for the individual that I'm working with, that we actually are creating change just in a kind of different way that I find that clients really respond well to.
Yeah, good responses, guys. And I think maybe the kind of voice I have in my head of people listening of, it sounds like the therapists are kind of not manipulating. That's probably not the right word. Although some people might think that of like, they're just praising me around this because they know it's an area I struggle in and But from what I gather with FAP is it's got to be genuine. Like you've got to believe what you're saying. You can't just say, I feel really close to you if you don't feel close to them. Is that fair to say?
Yeah, I would say this, and I'm curious what Meaghan thinks. I think what good ERP and good ACT and good FAP are, I see them all as related, is they are trying to watch for who is the person you're talking to at their core? I know this is going to sound a little hokey at first, so we'll put some behavioral bones on it, but like, who is this person at their core underneath their OCD and all of the things they're struggling with? And how do I pull that best version out of them by authentically tuning into that? And I think that's how Meaghan and I try to relate to our clients. We sort of try to see past like all of the CRB1s, the clinically relevant behaviors that they're doing that kind of push them away from connection and pull out who they really are. And I think that's what ERP does at its core, is helps people stand in face of fear in a way that feels really true to who they are.
And I think too, there's something to be said about that. It isn't, all sort of sunshines and rainbows or disingenuous in praise. What I always felt drawn to about FAP is that it is about that this is a real relationship. And in some ways, my job as the therapist is I'm really working very hard to know myself so well that my reaction, right, my response to the person in front of me and their behavior is a good gauge of, is this behavior that the person's engaging in creating connection and closeness, or just even like a healthy adaptive relationship? Or is it creating this distance, disconnection, disruption in the relationship? And I think even to speak to your earlier point, I think that's actually a very hard thing to do as therapists, is to know yourself well enough to trust that you're an objective gauge of behavior as best as we can be, right? There's obviously, we'll never meet the perfect mark. But I think that's sometimes why, many therapists I find are hesitant to that. It's like being able to use yourself as the tool in the therapy and not feeling very overwhelming. But I think, when I approach the work, it is very much my aim is to think of it as like a very genuine relationship. So if there are behaviors that are challenging or difficult, I'm finding a way to speak these, sort of name these, speak to these to the person in front of me in a way that's not shaming or sort of hurtful, but really thinking about how it's impacting us right in the here and now.
Yeah, I like that. Yeah, good responses. So why FAP for OCD? So why, in the sense of, I have these obsessions, these compulsions, these strong emotions that go along with it. OCD is ruling my life. How is working on how I am with others in the real world going to change my symptoms? Or is it not about my symptoms?
I think that there isn't enough research on this. You guys tell me at all. But I said this last time on your podcast, Stu, that like we know that close relationships are incredibly important to human well-being. There's studies showing that loneliness is worse for your health than smoking cigarettes or obesity. Like we really know that interpersonal connection is extremely important for people. I think the thing that I'm interested in, and Meaghan and I talk about this a lot, are a lot of mental health problems kind of symptoms of expressions of interpersonal disconnection, meaning not actually feeling close to who you are and how to express that to other people in a way that makes you feel connected. And by the way, I'll bet there's a lot of people listening to this who are like, man, that sounds like a reach. I don't know. Like, I really think this is worth us talking about, is like, it's not in any of the OCD treatment manuals. There's no chapter on authentic self-expression. Like, you go look, there isn't one. But Meaghan and I think, can say this pretty confidently. When we get patients expressing themselves authentically with us, they do better with their OCD. And we'll give case examples in a little bit, but I think there's a strong link between interpersonal disconnection and mental health problems, and FAP targets interpersonal connection.
Yeah.
I think even sort of like in a very concrete way, I know often Nate and I will see folks, at McLean here, and for many a period of time for this individual, right, it's been a focus on symptom reduction. I do the ERP, I sort of nail down my symptoms, and that's sort of what quote unquote will make me better. And sometimes I think of FAP as like having its like strongest utility in almost like phase 2, where, okay, like I've got my OCD into a place where I can really sort of manage and turn outwards towards my life. And someone either because of how pervasive their OCD has been, other factors, they don't almost have the skill set on board to foster genuine connection and closeness in their life. And they're sort of left in this sort of like intersection where I can turn back towards my OCD and just keep doing ERP and make sure my symptoms go down. But I'm also sort of lacking like this very important domain or component in my life that I actually don't know how to relate to others. I don't know how to sort of step into the person I want to be. And I think of that so much as we start to lower sort of OCD symptoms and through ERP, through ACT, all the things that we usually do, FAP does have this like beautiful way of folding in like a next step for the person that they're equally sort of fostering and building up interpersonal skills.
Yeah. Yeah, I like that. And I think, sometimes it will directly overlap with OCD symptoms anyway. Several clients of mine come to mind where, because I work with children, young people, and if confessing is a big compulsion or asking for reassurance, they're in the therapy room with me, confessing to me continuously, like there's no room for actual human connection. And then I know they're going away to their parents and they haven't had a decent conversation with their parents in like 2 years. So, one client comes to mind where I wasn't using FAT, but we directly targeted that of in the session, we're going to have a normal conversation. Every time you get distracted, we're going to bring it back. And then I was reinforcing, that it feels really good talking to you in this way. I feel like I'm getting to know you, blah, blah, blah. And I meant it. And then slowly this client started to have genuine conversations with their parents again, and they felt that closeness and that connection, and that made a world of difference in their lives. So I think that for me is just an example where the two directly overlap as well, symptoms and interpersonal stuff. So just looking at my questions, I guess I wanted to ask around like a typical FAP session. Are you just bringing in FAP alongside maybe the ERP ACT work you're doing? Are you dedicating sessions to the FAP targets? What does it kind of look like?
Is this where we should do case examples, Meaghan, or do you want to respond to what he just asked?
Yeah, I think I could probably answer the question best through a case example. I think,
Sure.
Someone comes to mind where, this individual came to me and our residential treatment to target sort of intrusive thoughts or fears of catastrophic things happening to his home. And so a lot of checking behaviors, a lot of sort of compulsive, almost like monitoring of his home, monitoring of weather, looking through his home for like potential, pitfalls of where essentially, at the core of it, he felt like his life would fall apart and sort of his home was this thing that he could control. And in exploring sort of and understanding his core fear really was that I would be sort of incapable of handling a disaster and my life would fall apart. My wife would leave me. I just would be left in ruins and I would not be able to handle that. Mm-hmm. So initially in first meeting him, we do very much just at a very kind of traditional standard ERP approach, right? He watched videos of like home improvement shows gone wrong, weather events occurring. He sort of deleted a lot of the applications on his phone that helped him sort of monitor, weather events or his home. But within sort of like the first 2 weeks of knowing this individual, what stood out to me as like quite interesting was that, yes, the ERP was like generating anxiety. He was sitting with distress. He was doing the things that he really needed to do. But almost in this like overlap of fear was this like feeling of like low self-worth. I don't feel capable in my life. And a lot of his relationships, not just with me, that it started to sort of present itself, but very much with his wife, his mom, particularly female individuals in his life, was this sort of inability to self-soothe, sort of overly reliant on seeking out another person to manage his emotional experience, but also simultaneously pushing those individuals away to sort of feel confident or feel secure within himself. And that was very apparent in our relationship. And it sort of took a few sessions to realize like what was happening, right? Like this grist for the mill idea, like what is happening in the here and now is, very much this person coming into therapy saying, you need to fix me. You need to do the work for me. and tell me what to do and how to live my life. And then feeling very much sort of rebuffed or upset at me when that like either didn't go the way that he wanted it to, or very much creating distance through conflict, sort of creating conflict in our therapeutic relationship. And I think that sort of was this like moment, like light bulb moment of like, this is where I'd like to use FAP. I think this would has a ton of utility, and starting to very much like rule number one, like watch for these behaviors and how frequently they're occurring. So for me, that's a huge job of even some of the initial sessions, kind of tracking these behaviors, and to myself, naming them and seeing, what sort of, response I'm getting when I do evoke them, and gauging like how he is receiving then what I'm reinforcing, whether it be sort of trying to promote more self-efficacy, expressing, feeling quite distanced or misunderstood in moments when conflict was created. And eventually, sort of probably around session 6 or 7, I would say, is sort of sharing this with him of that I'm noticing these behaviors are occurring in real time, and getting a better sense of then like how the history of these sort of like presenting CRB ones, and did this show up with his wife or did this show up with his mom? And it was very apparent that it was pretty pervasive across his relationships in his life. And then discussing like how we might work on that, and sort of dedicating our sessions to FAP, while still all the while when he's working with our ERP coaches, doing these sort of exposures to kind of maintain that piece of it.
Yeah, that's interesting. How did he progress with FAP when you switched more to that?
I have to say, I mean, like objectively, right, it's difficult to toot my own horn, but I think he did quite well. It was very much sort of almost this like lighthouse effect, right? Of this is something that he always interpreted as sort of just something wrong with him. And sort of his own, again, incapabilities, I think very much both as like a person, but also as a man. And it gave us this ability to, I think, bring him more as an active participant in the therapeutic relationship rather than sort of sitting back saying, well, you tell me what to do. He was able to really engage more fully, I think, in our sessions. He, at the end of treatment, said, like, you're the first person, being a therapist, but like you are the first person that I've actually felt my most genuine with. And I've felt that actually this was a real relationship, where historically I have sort of used therapists to get what I need, but it's never translated to improvement in my life. And this is the first time I'm sort of seeing it as like this is an extension of my struggles in my life. And I get what I need to do differently back in my life now. And I can sort of understand in real time.
Yeah, that's interesting. The bit about where he said he's kind of used therapists before, and I've definitely felt that way with clients where like they've just come in, they're like, fix me, and there's a distance, and it just feels like the work's not going to work. Nothing's going to work here. And I don't know. I wonder if that's just a byproduct or side effect of the more evidence-based therapies like CBT over the years dominating, that we've lost this idea of actually therapy is about a relationship. And maybe that's why, I don't know if it's a trend. It's just, but.
Well, I think that what I noticed about what Meaghan said is that I can't see her or me at this point in my career doing therapy with someone where we don't talk about those things that she started noticing were happening in the relationship. But I think that a lot of evidence-based therapists, including in the OCD world, they don't talk about them. Some of them don't even feel it, but I think a lot of them feel it. They just don't know what to do with it. And so they just kind of set it aside and focus on what the patient came to work on. But Meaghan and I are trying to say, like, we actually bring up the things that we're feeling in the relationship, which is often the first time they've heard it from a therapist, because a lot of therapists don't tell them these things.
Yeah, and probably also maybe even the first time they've heard it in a calm way, because maybe in their own lives they're getting attacked by their loved ones of, why are you like this? Why do you always do that? Versus, You can't do that as a therapist.
Yes.
You have to be more caring and considerate in your responses.
Completely. I mean, I think it's truthful. I think there's a therapist actually here at the OCD Institute that always comes to mind when she often will say, like, I respect you too much to not tell you what's going on. And it just, I think, like, rings so true to me all of the time. I mean, she's a remarkable therapist, but I think that's sort of, for me, almost at the center point of FAP is that if I can really be calm and compassionate and objective and engage someone in a conversation to help them improve their relationships outside of here and use our time together as a means of practicing that and not just intellectualizing it and talking about it as an idea or something abstract, but really learning through experience. I think it has so much more power than to actually translate in the ways that a patient might want.
Yeah, absolutely. Yeah, good point. And Nate, is there any other sort of case studies you want to add to the mix?
Yeah, I'll give one that is recent. It's a good example because it's a patient who was referred to me by someone who used to work at the OCD Institute. She works at another clinic in Boston, and she's an amazing therapist. But I remember when she referred this patient here, she said something like, and I think Meaghan can relate to this. She said, "Oh, I hope this person gets Nate when they come to the OCDI," which I think means I hope that she gets a therapist who talks more about what's happening in the relationship. And so she comes in and she looks like a classic OCD patient. She does a ton of reassurance seeking, checking, repeating behaviors, gets a very emotionally dysregulated when she's struggling with all of that. And her mom, I'm sure everyone listening can relate to this. Her mom is incredibly engaged with these symptoms, so reinforces a lot of them, accommodates a lot of them. And the thinking, I think, from this therapist was she needs a higher dose of ERP for sure, maybe some relational work. She didn't say that. But I was trying to do the higher dose of ERP with this patient. So we were giving her a ton of coaching for showering, changing, all of the activities of daily living she has to go through without doing checking, repeating, reassurance seeking. And she wasn't getting any better, and I could see why. There was a huge dependency on the staff as she was going through that. And you could just feel it almost like this people-pleasing quality of like, really nice woman, but like wanting to connect with me and the other staff around how well she was doing in the ERPs. And I felt totally disconnected from that. And in fact, I felt like this is not who she really is. This kind of success with ERP is not something I'm relating around. So this is what's great about working at a clinic like ours. I got all of the staff to commit along with me to stop working on her OCD and to stop talking about her OCD and to just work on getting to know her and then just reinforcing all of the things she was telling us that were really true about her. And she's so much better now that, like, I just saw her yesterday. I'm seeing her privately now. You almost can't recognize her when she comes into the office. She's just talking about her dating life, her friend life, this apartment she just moved into. And I remember in one of our last sessions at the OCDI, she cried for pretty much the entire session about how it was so hard for her to say goodbye to the staff here because it was like the first time in her life that she felt the staff and the people here really saw who she was as a person, that she really had struggled all of her life with insecurities and self-doubts and people-pleasing and didn't really trust that she could show up authentically with people and that they would really understand her. And I could see that like something profound had changed inside of her relationally with all of these staff. And I'm throwing this out to the audience here to say, like, she got better without ERP, meaning it was actually ERP was making her worse. In this, if you're going to call ERP like blocking, repeating, and checking and reassurance behaviors while she's doing activities of daily living, that was making her worse. Authentic self-expression and putting herself out in her life in kind of an active, values-based way, while learning how to be who she really is, that's what got her better. And I'll say one last thing on this. When she was leaving my office yesterday, I let her into a bathroom, and she had asked me to let her in, and we were saying goodbye. And then she looked at me and said something like, goodbye again, with kind of that reassurance look in her eye, like, are we good? That kind of look. And I'm saying that to the audience just to say, like, that's kind of who she is. There's like a self-doubt in her about like, are we good? And I think the staff here really learned how to connect with that part of her in a way that wasn't reinforcing her dependency, but was pulling out her confidence.
Yeah, that's really interesting. It makes me think of a particular client I'm working with. Yeah, that's really interesting. Okay, so yeah, you've gone down the route there of, well, actually, yeah, it was ERP at that point for that case, had nothing to do with it. And of course, you're not saying FAP is the answer for everyone. You're just saying in certain situations, it might be an option.
That's why FAP matters so much for a patient like her is, and I left this part out. So she's seeing me privately, and now she's seeing the old outpatient therapist privately as well. I'm kind of bridging the transition back because she did such good FAP work here. And I said to the outpatient clinician who's interested in FAP, are you sold now on FAP? Like, are you going to do this with her? And she was like, I'm all in. Like, this is a changed woman coming back to me. And so why does this matter? Because this comes down to CRB 1s and 2s. So if you said this patient taking a 10-minute shower, which she did with me early on, coaching her, without rituals, and then telling me how proud she was of taking a 10-minute shower, if you said that's a CRB 2, meaning an improvement in her life, I think it's wrong. I think it's a CRB 1, meaning I think she's trying to connect with me around success in an ERP, but she's not connecting with me around authentic expression of her insecurities that she struggles with in her life. And we can talk more about that. But I think a lot of clinicians think that progress in ERP is always a 2. And Meaghan and I are trying to say it depends on the function of it. Sometimes it really is, and you should be doing ERP. And sometimes it's pulling them away from authentically expressing what their core struggle really is.
Yeah, very much so. Like, it all comes down to the function of the behavior. Like, sometimes it is very much like a bid for connection. And this is perhaps like the only behavior that this person knows how to create closeness or connection in their life. And we're looking at the function of that and actually going like, that's actually a 1, right? That's creating distance between myself, the other staff members, her peers, right? And we're being able to see them in the context of their own environment. And I think that just sort of gives us an extra sort of option, that there are lots of folks who come in here and very much so like, oh, we're just doing ERP, right? Like, that's sort of our sole sort of intervention. But sometimes when these individuals who have come in of like ERP maybe hasn't been successful, and we can't quite pinpoint like maybe why that is, or, intellectually this person really understands and gets what ERP is, but there's just something that isn't generalizing for them in terms of well-being. I think that really does give us this extra opportunity to kind of look at sort of the interpersonal behaviors more closely and target those in a very, I think, effective and more organized way.
Yeah. Absolutely. And I think what you're saying there about, maybe if I heard you right, the OCD is their way of communicating. It's how to get their interpersonal needs met. I guess if we think of symptoms generally, they're a symptom of something, be that a serotonin imbalance, something gone wrong in the brain, or trauma, or maybe in what you're saying, in some interpersonal issue that they've never been able to express something or connect in a deep way, or
Meaghan, do you want to say anything about how you determine what's a one and a two? Because this is something we talk about a lot. I think this is something clinicians are probably listening and they're like, yeah, how would you have known taking a 10-minute shower was not a good thing?
It's very much for me, I think, sort of this sort of like deep dive when I first sit down with someone. I am really, yes, like trying to take an inventory of like their OCD symptoms, like where sort of OCD is creating challenge in their life. But I also pretty quickly am tuned into, what are their relationships like? Like perhaps if someone's had a lot of ERP treatment, it's like in a very compassionate way, getting curious, like, like what hasn't worked then? Like really what has sort of either kept us stuck, maintained the OCD, and really started like from the initial intake to really understand this person in the context of their environment, like how they are not only showing up with me, but peers in the milieu, peers in their life. I'm also someone who's like very tuned into like nonverbal behavior. Obviously, like I almost would consider myself a body-based clinician in a lot of ways. So I am sometimes looking at affect, either excess of or lack of, thinking about, when they're talking about really difficult or painful things, how are they communicating that, both in the content of what they're saying, but also how they're saying that, how they are either looking to me or looking to peers, right, in the milieu to almost gauge their own impact. And so like I can see them almost tracking, how am I being received, right, by others around me? And so a lot of that is I'm thinking about perhaps like behavior that other clinicians might just set to the side. Like that for me is that I'm very much attuned to that from the moment like someone walks into my office of how is this person connecting with me, peers, and understanding just historically how this has worked for them. Like important though, can be challenging to track and really articulate how you might define the behavior and why you're sort of labeling that behavior as a one or a two and why.
I agree. I think
this is just so. Oh, I was just going to say this is so like important what Meaghan's talking about because like I see Meaghan as a clinician where she can say things that she's picking up on, and I do this too, where it's kind of hard for me to articulate exactly why I'm feeling the way I'm feeling about it. Like, let's give an example. Like, is crying a one or a two? It depends on how it's functioning in the relationship, but also how you're experiencing it. And I think Meaghan is someone who like, she's kind of wired this way where like she can just pick up on this stuff. Whereas I think a lot of clinicians, when they got trained to be therapists, they like read a lot of books on how to like say the right thing, but they didn't learn a lot about like how to deeply tune into and see what your patient is really communicating to you. And even as I'm saying this, I'm like, God, there's so many CBT, ACT people, ERP people listening to this who are like, what is he talking about? Like, how do you read into like deeply into someone's, but I got to tell you, Meaghan, I think has been told this by patients. When I'm doing good FAP, patients say to me, I feel like you're seeing through me. You're like seeing through all of the things I'm saying to like what I'm really feeling.
Yeah.
It's sort of, I like to think about I know in physics, and I do not have a math or physics brain whatsoever, but the sort of concept of attunement, right? It's sort of aligning your frequency to another frequency. And in some ways, that's not just sort of an intellectual process. That is something what we might say like a bottom up process, right? That I'm attuning to how someone is feeling in the moment and trying to track that. And it is behavior, right? Like I think it's challenging sometimes because we have these very amorphous experiences that we're trying to put language to in some ways that it is a very intuitive process. And so we have words in fact like authentic or like close, deep, meaningful connections, right? And vulnerability. And it can be difficult to place a language to what is being experienced in the room. But I think FAP has like always done for me, like why I just feel it felt so validating, right? As sort of someone who came from a very different orientation, who wants to do really, again, good evidence-based behavioral work, to then have sort of a map for how to do that But much like any of us would do with good OCD work, right? Is someone crying while they're talking about their intrusive thoughts? Like, does that function as a potential ritual, right? And alleviating the distress. Like, we're looking at the function of that behavior. And with FAP, we're just looking at the function of that behavior as it pertains to the relationship.
Yeah. Yeah. It's just, it's getting me thinking a lot, which is why I'm lost for words. I guess as you guys talk, it just brings to mind, stuff with my clients, but not just that, because I think I'm more alert to it's like stuff in my own personal life. So yeah, all that stuff's coming to my mind. But yeah, I guess the hardest thing I've found with FAP is I've got my head around like the core principles, and in a very rinky-dink way, I use it sometimes with clients. But I've struggled with how do I really formulate in my mind the CRB1s, and then when am I reinforcing? And so when we do the training, obviously, I'm sure you guys will cover that, and I personally am really excited for the training.
Well, so that right there, Stu, is like when Meaghan and I are preparing to do this training, we decided that we wanted to try to videotape our sessions to show ourselves doing this, because people are probably listening to this podcast and they're like, how would you actually know what a 1 or a 2 is? And then how do you actually reinforce it? I think that they're really wanting to see that. And Meaghan and I can show that easier in a video than we can just describing it. But I'm going to say it this way. It's a vibes-based therapy. It's like when Meaghan was saying tuning, it's like you're sensing this nonverbal stuff that's happening, which, by the way, I think that's over 50%, maybe more, of what people actually need to focus on in therapy, is these kind of nonverbal things that are either on or they're off in the relationship.
We'll put it in Meaghan's concept. It's a dance, right? It's that back and forth.
Very much so. Like Nate mentioned, emotionally focused work. Like Sue Johnson really often will talk about that within couples, right? That they're entering into this dance with one another. And she'll speak about sort of like speaking through someone's amygdala, right? That there is affect occurs like in our bodies. I sort of will make even this joke with many of my patients here, like none of us are floating brains, that it's, we can't sort of intellectualize our way through this. And that, both in ERP, right, it's important to connect to the affect, but also in a relationship, how integral that is. And, FAP does really ask that of us, both as the therapist, right, having our own 1s and 2s, as much as, the person we're sitting down with has their 1s and 2s. And how are we trying to actually like enter into that dance together and course correct is when we need to.
True. And even if we say, look, FAP has no impact on OCD, of course, that's not what we're saying. But even if we were very conservative about it and said, it's not going to change symptoms, well, if it improves interpersonal relationships, it doesn't matter if you've got your OCD right down. If your relationships are dire, you're going to be miserable. So it's even from that lens, as a bare minimum, it will make a world of difference to people's lives. Cool.
Completely agree.
Yeah. So is there anything else you guys wanted to share today on this?
I mean, we're doing a 4-hour training on this, so we could talk about it for hours, but I don't know. I guess maybe one question I have for you, Stu, if you're up for it, is like, why are you so interested in FAP? You've had me on the podcast 3 times. You've asked us to do a training on it. Like, what draws you to this kind of work?
Yeah. I've not thought about it in detail. I mean, the first answer that comes to my mind is, I did 8 years. I mean, about 4 years of that was 3-4 years was fortnightly. But yeah, 8 years of humanistic / psychodynamic therapy with the same therapist, Annabelle. And I ended March last year, and she didn't use FAP as far as I knew. And this wasn't for OCD. I had got my OCD somewhat under control by this point. It was more working on other stuff in my past and how it was showing up for me now in my everyday relationships. And just the safe, secure relationship I had with her. She challenged me at times when I was shutting down, because that was a big thing for me, is not expressing emotionally. And it's something I still work on. And at times I think she did do a semblance of FAP without being structured with it. But the key thing, I remember once I always struggled to show affect, and unless it was, say, anger, I wasn't angry, but it was easy for me to get annoyed about stuff. But in terms of sadness, emotion, that sort of thing, I would shut down. I remember one time she just kind of looked at me as I was talking about something I know was troubling, but for me, I was so disconnected from it. And I looked up and I could just see she wasn't crying, but her eyes are glazed in like a teary way. And for me, that expression of, I felt love, and she was showing me my emotions, and that really helped me. I remember it to this day. It was probably the most meaningful thing she did, and she didn't say a word, but it helped me calibrate in such an important way. And she could have hid that emotion, as some therapists would, but she didn't. She put it out there, and that was so meaningful for me. So just the relationship I have with her, and if I have issues again in life, I'll go back to her for a bit, no doubt. She'll always be someone who's incredibly meaningful in my life. I respect and understand the boundaries between me and her in therapy, but that's probably why she really changed a lot for me, just by being a great person and being a loving presence and challenging me when I needed to be challenged. So yeah, I see the power of it, I guess, is what I'm saying. And that's why FAP. I love ERP, ACT. I'm learning about ICPT and other stuff, but for me, the relationship's just not there, and that is a big issue for me personally, and that's why I like FAP.
Yeah. And I just want to say something to reinforce what you just said, Stu, and curious what Meaghan thinks. I think that you are interested in this because the way I experience you is you're like a sensitive guy in like a really good way. Like the way you run this podcast is like so tuned into what your guests need and like to make them feel safe and comfortable. I told Meaghan before she came on, I was like, Stu is such a nice guy. He's going to make you feel so comfortable. And I just sense that about you, that you are sensitive, and that may be partly what draws you to more relational work.
Yeah. No, thank you. Yeah, well, I appreciate that. I think I was very sensitive. I am, but always as a kid, and maybe the environment I was in didn't allow for that. But no, I appreciate that.
I was saying to Nate, so like, these things are very much not my cup of tea. Like, I think it took a lot of coaxing to have me join, but I think even in that response, right, it like really did sort of like warm my heart, because I can see you then, right, like transitioning into your own work with the clients that you work with, and being sort of having an access to that reference point of like, this is how I want to be showing up, and sort of embodying compassion with the folks that I work with in a way where I understand it for myself. I have those boundaries. I really can, put some reins on it and understand how I want to, bring something really special to the work, which I think has always been something that, has felt so deeply meaningful to me, is that I do think I'm a terrible liar, and I do think of myself as I'm showing up as myself as a therapist, and having a little bit of an ability to do that, I think for me prevents burnout. Like, it allows me to very much so like be myself, treat these relationships as sort of like these very joyful and meaningful, like paths crossing, right? That if I get to show up really as a person, myself as a therapist with the person I'm sitting down with, like that, it's a real privilege, frankly. But then to be able to genuinely connect with somebody and use it in the work that has such utility, it's very special.
Yeah, I agree with that. I think, the days I leave my office and I've not been able to connect with people, we've been way too structured about things, I feel tired. I feel exhausted. I'm not looking forward to tomorrow. And then the days that I've really connected with people and had deep, meaningful connections, like I leave the office really excited, happy, content, excited about tomorrow. So yeah. Yeah. So look, thank you so much, guys. I mean, I love talking about FAP, anything relational, as well as evidence-based therapies. So, I really appreciate you guys coming on. I'm excited about the training. So any therapists listening, that want to do that, and a link will be in the show notes and stuff. But thanks again. I appreciate it. Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us, please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. If you want to find out more about NoCD, head to go.treatmyocd.com/the OCD Stories or click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.